The purpose of this video is to explain the need for hormone replacement therapy in adolescent girls with Turner syndrome. Puberty is the process which leads to the development of secondary sex characteristics, such as breast development, as well as maturation of the uterus and its lining. This process is initiated by hormones, particularly estrogen, which is produced by the ovaries. At the beginning of puberty, a part of your brain called the hypothalamus releases a hormone called gonadotrophin-releasing hormone, or GnRH. This stimulates the pituitary gland, which is another part of your brain, to begin to release two main hormones: luteinizing hormone, LH, and follicle-stimulating hormone, FSH. These travel in the blood to the ovaries, where they stimulate the production of estrogen. They also have an influence on progesterone. The first sign of puberty is the appearance of breast buds. The menstrual period will usually begin 2 to 2.5 years after breast development starts, once the lining of the uterus is mature, and causes the lining of the uterus to shed. This keeps the uterus healthy. 4 main hormones control the menstrual cycle. These are LH, FSH, estrogen, and progesterone. These hormones interact with each other in feedback loops. At different times of the menstrual cycle, these can be high or low. I will now describe to you what happens to these hormone levels during the menstrual cycle. The average cycle lasts 28 days and is counted from the first day of your period up until the first day of the next period. At the start of the menstrual cycle, estrogen, which is in pink, and progesterone, which is in blue, are really low, and this causes the uterus lining to break down and a period to occur. At this time, levels of the hormone FSH in green start to rise, which stimulates the development of follicles in the ovary. These follicles contain an egg. The development of the follicle causes increased estrogen production. Once estrogen levels become really high, this triggers the release of the hormone LH in orange and a smaller release of the hormone FSH. This causes the ovary to release the egg from the follicle, and this time is called ovulation. At this stage, estrogen starts to decrease, but progesterone begins to rise. After ovulation, LH and FSH levels go down, but progesterone levels continue to rise. The mix of progesterone and estrogen cause the lining of the uterus to become really thick to support a possible pregnancy. If there is no egg fertilisation in pregnancy, progesterone and estrogen levels decrease. This causes the lining of the uterus to break down and is the start of a new menstrual cycle. Don't worry if you find this section tricky to understand. It's really complicated. In Turner syndrome, the ovaries do not work as they should, and around 90% of young women with Turner syndrome develop ovarian insufficiency. As we chatted about in the menstrual cycle section, the ovary need lots of follicles with eggs to produce enough estrogen. In Turner syndrome, there are usually much fewer follicles. This means ovaries cannot produce enough estrogen to start or to maintain puberty or to have menstrual cycles. There are some blood tests that can be done to help predict who will go into puberty without needing estrogen. Your doctor might mention checking the levels of the hormone FSH that we chatted about earlier, or anti-Müllerian hormone, AMH. A really high FSH suggests that the body is trying super hard to stimulate the ovaries to make estrogen. A low AMH tells us something about the number of follicles in the ovary. If the AMH is really low, there might not be enough follicles for estrogen production. A high FSH, low AMH and low estrogen together suggest that estrogen replacement is needed. It should be noted that development of pubic hair is not the start of puberty. The development of pubic hair is controlled by another organ, the adrenal glands, and not the ovaries. If there is no breast development by 12 years old and you've had blood tests that show the ovaries are not working to produce estrogen, the doctor may start you on estrogen replacement. We start giving estrogen replacement at this age so that you go through puberty at a similar time to other girls. Estrogen is started at a low dose and then the dose is slowly increased over 2 to 3 years. This gradual increase is to mimic puberty and to allow time for normal breast and uterine development. Estrogen can either be given as oral tablets or it can be given just as a patch that you stick to your skin. It is super important to take your estrogen replacement. Estrogen is needed for lots of bodily functions such as healthy bones, your ability to learn and remember things, and for good mental health. After 2 years of estrogen, or when you start to notice a little bit of breakthrough bleeding, this means that the uterus and the lining of the uterus is likely quite developed. At this point, we add in the other hormone, progesterone. This is given for 10 days of the month, and this causes a period to allow the uterine lining to be shed and keep the uterus healthy. You have some choice over when to have your period, and you do not need to take progesterone every month, but you should have a period at least once every 3 months to keep the uterus healthy. Some girls, instead of taking 2 separate tablets, may just take 1 tablet which has estrogen and progesterone. This does the same job. Your doctor will explain how and when to take your tablets to you depending on the type you have. It should be noted that hormone replacement therapy in Turner is not the same as in other women. In Turner syndrome, your hormone replacement therapy is replacing what the body is not making itself. It does not come with the same risks that you might read about in the medicine information leaflet. If you have any worries, you should speak to your doctor. We hope you found this video useful. With thanks to Arlene Smythe, Dr Avril Mason and Gabriella Currie.